Appreciate everybody who signed on today. I will turn this over to one of my colleagues, Tyler Anstadt, who's helping me with this initiative. I also like to introduce Amy Lopez, who's from the CU's legal office, who joined us today to have this discussion, and Patrick Guffey, who is a CMIO at Children's Hospital, and they've had a lot of experience with this already, so they have joined us for this discussion also. And I don't see anyone else. Kelly may join us, and I'll introduce her if she does.
By yourself.
Oh, Kelly. Okay, hey, Kelly. Kelly Bookman is also joining us.
You guys want to
separate at UCH. So, so Tyler, do you want to start with just a brief overview on some of the information, and then we can, after he gives that kind of high-level overview, then we can open it up for questions or concerns.
Yep, absolutely. Thanks. Thanks so much for having me. Thanks everybody for being here today. I'm going to walk through some basics of how we landed where we are today, some background information, which you may have gleaned from the FAQs that are posted on the Clinical Affairs website, to answer, I think, a lot of the questions that we've been hearing as we're on this roadshow. And then after I go through that, we'll open it up to questions from you all, both for clarity and for understanding what are the next steps. So I'm going to share my screen, go through a few prepared slides. And again, that's meant to get everybody on the same page. And then we'll go through and open this up to you all, because this is your town hall, and we want to take notes and understand from you where are your questions and where are your concerns. So on screen. All right. So here's our overall vision for unified communications. And this is borrowed and adapted directly from UC Health, who's actually been on this road for a while, Children's Hospital as well, where the vision is to radically modify how we communicate in our health systems, moving really into the 20th century, building a communication platform that's connected to the patient's chart, such that you know when you're getting an alert, when you know you're getting a message, you know which patient it's about, and identifying and getting messages to the right person at the right time that minimizes disruptions. I think we can all agree now that it's pretty scattered in terms of our communication, both with pagers and phones and Epic messages and all these other things. So really the idea is to do this in a conscientious way moving forward, so it's streamlined for everybody. Our values are listed here on the screen, and a couple that I bolded here are specific to this discussion. One, minimizing the number of electronic devices in the 21st century with multimodal devices. It just doesn't make sense to have the old pager bat belts that people used to wear when their pants would fall down. It just doesn't make sense anymore in our age of technology. And then really want to highlight that this has been one of the first times, but a great opportunity to align between our affiliated institutions under the umbrella of the School of Medicine, such that transitioning between institutions feels a lot more seamless than I think it has in the past. So this has been a really nice opportunity to collaborate across our institutions. So, and the other thing I want to sort of people to go into this discussion with is we need to have a growth mindset about this, that it really is not just simply replacing one technology with another. It's really, how do we reimagine all of the work that we have, including our communication, such as what is the next evolutionary step to make patient care and wellness better in the places that we work. So we will really miss an opportunity here if we just simply insert cell phone for where pager used to be. There's a whole lot now technology that'll drive our new practices. So be thinking, how can this new technology, how can this change in platform actually create opportunities for better communication, not simply how do we replace one with the other. So a few institution specifics, and then I'll get into some more nitty-gritty details. For University Hospital, Children's Hospital, and Denver Health, you can imagine, because they're all on Epic, that the communication is going to come through the Epic Haiku mobile application, as well as the desktop, and how things happen now. So those institutions will look rather similar. There's a few call-outs that I have here where they will differ a little bit, but largely, relatively, what we say for one is generally same for true. And we've been doing a lot of work at each of the hospitals, doing custom builds for every service group, line, whatever that looks like. So if you've not heard about this, then we're not doing our jobs trying to communicating it, but there's accountable champions identified for every single department, division, and training program. At the VA, because there was always a question of what about the VA? In-house, not much is going to change. So for right now, they're going to continue with their VA service line pagers, as well as expanding some of their Vocera badge device options for different teams. What's going to change is where there's a pager, insert cell phone for where pager is now. They're moving along at the pace that the VA does, but they're looking at secure messaging, probably through a secure messaging application like Volt, but that's very much TBD and really highly dependent on a lot of other moving factors at the VA. So they're coming along as well, but this is the near term, what's going to shake out at the VA. So a couple notes about some of the payment part of this, because I know that's one of the big questions or concerns that people have. For residents and fellows, they're getting a $150 one-time payment this academic year. We're exploring and in their discussions right now, what is it going to look like in years to come of adding compensation or a stipend to the base salary. And this is in addition to they're already getting a salary increase as part of the negotiations that the House Staff Association was able to leverage this coming academic year. For faculty, it's going to be very department or division specific, as most things in our institution are. So every department or division's got to decide where they want to spend their money, and is technology one of those things? And admittedly, there is a CU system reimbursement policy. Currently, it's based on minutes used. And so working through the channels of the CU school system to change what that looks like in terms of submitting for reimbursement. And is that, how does that make sense? So a couple notes on HIPAA and privacy. One of our biggest impetus for doing this is we felt that our institutions were very vulnerable, including you all as faculty, by using pagers, because unfortunately they're not encrypted for PHI. So we're at huge risk for HIPAA violations continuing to use pagers. And just to say, texting patient information, texting PHI is definitely not secure, and so not something we should be doing, even though we all know that that happens on a daily basis. I would argue that all the functionality that you would want to use a personal cell phone for texting, for paging, all of that is available within the Epic Haiku mobile application, taking pictures, attaching them to patient's chart. So really, you shouldn't have any excuse for using your own personal device in terms of the native software on there. That's not through the secure mobile application. Now, there are a lot of concerns about privacy, and we'll dig into that in a second. But one of the things in terms of sharing your personal information with the world, a couple different things. One is that where personal cell phones are listed on Amion, each of the institutions is either doing away with Amion. So Denver Health is moving to having everything within the EHR, so behind a password. University Hospital is moving towards changing the Amion password from the standard UCO that's been there forever to a single sign-on, so having to use your credentials to log in. So putting that more secure. And then we're in discussions with the VA about doing that same thing. A couple other options, in addition to not listing your personal cell phone number, you can choose to purchase either a separate phone, although we think that's cumbersome should people want to do that, but you can essentially have the same functionality by purchasing an eSIM, which is significantly cheaper than buying another phone, through your cell phone carrier now. A free version of that is using Google Voice, where you can use Google Voice, you can set up an account and have that linked directly to your phone. That also adds some nice functionality because it's a mobile application that you can designate what the alerts come through and how they look. And then finally, for faculty with an existing campus desk phone number, there's a free option called Cisco Jabber that's available on the OIT resources webpage, where you can set it up such that your desktop phone number in your office will now ring through to your cell phone. So that's another option, and really negates you having to list any sort of personal information. If you don't have a desktop phone number, you can designate another number. It just comes with a fee of $15 a month. So a few notes on backup devices. This is going to look differently at every institution. So each institution has their different version of what the backup devices are going to be. Largely, it's going to be that the hospitals are not going to provide backup devices depending on what the code alert mechanism is. So at University Hospital, there'll be a few limited phones available for backup things for people on code teams. At Denver Health, their code alerts are not going to come through in the mobile devices at all. So that's separate. Children's Hospital has a process in place, and then the Rocky Mountain VA, they're continue with overhead paging, so they won't have a backup option. I'm going to put an asterisk on this because we're in active discussions, and this is going along with that growth framework of like, is this feasible for each of our institutions and for school medicine faculty? Do we need to explore other options? And we're having those conversations now. So just know that this is not necessarily set in stone, and we're still trying to be nimble as we move along this path. So here's a rough timeline for you. So last Friday was the deadline to have numbers updated in MedHub and in Amion. You can still do that. The place we're advising people to do is within your CU employee portal. The stickiness comes if you want to have a separate phone number for your work phone number versus your clinical phone number, and just work with your division administrators on where those things are posted and what number you specifically want posted. Moving forward, starting this Thursday and then into next week, both Denver Health and University Hospital are making such that the functionality is totally there. In fact, most of it's already there, but moving towards functional provider teams such that you can start playing with this now. And I strongly encourage everybody to do that, to find the problems in the system, to test this thing out, to figure out how this is going to work for you and your teams. On June 15th and July 1st, we're not distributing new pagers to any incoming residents or fellows. On July 15th, Denver Health is moving towards changing their consult notifications to go through Epic as opposed to how they work now. And then finally, kind of the biggest date in here is July 26th. That's where University Hospital is going to fully transition to having all alerts come through the Epic mobile device, moving away from pagers. There's going to be a dual sort of pager alert and Epic mobile alert for about a week, so we can make sure that the system's working adequately. And then around the 1st of August, we're planning to have kind of RIP, thank you for all the service that you provided us for the last 70 years. For pagers, and then work on a collection scheme, because unfortunately you're not able to plastinate it and keep it as a paperweight. They are school of medicine devices. So let's dive into some of the FAQs that I know you've been sort of chewing on, and we'll see if other ones come up. So we've already talked about the privacy piece in terms of ability to supply an alternative to your personal cell phone number. There have been a lot of questions about Wi-Fi access and cellular access. I want you to keep in your mind that most of the work should really happen over Wi-Fi. That if you're at home managing home call, if you're at work managing work at work, you can be onto the Wi-Fi and not have to use or update your cellular data plan really at all. Both University Hospital and School of Medicine are updating their Wi-Fi access points and upgrading their Wi-Fi. But if you have signal issues, say, by the windows on the 3rd floor of X tower, you can certainly call the IT desk and say, hey, this is exactly where I'm standing and I don't have service in this area. And they're open to those things, but you've just kind of let us know where those things are. One of the other concerns that has come up is around work-life balance. So this is an intrusion on work-life balance. We think this is going to get a whole lot better for the entire system, meaning for nurses, techs, laboratory, everybody involved. So right now, let's be honest, you turn off a pager when you get home, and the other end of that line, when someone sends a page to an off pager, they get no feedback that you didn't get that message. So there's going to be functionality coming to the Epic mobile application where you can set yourself as offline. That will notify the sender that they can't even message you. So they need to be looking for somebody else. So that's functionally being able to turn off your mobile notifications through the Epic Haiku application to say, I'm not available, you can't message me, look for somebody else, as well as other things to communicate to others, like totally available, open for your messages. I'm busy, but if you really need me, do not disturb me, like really don't bother me unless it's life or death, and then truly can't be messaged through that offline feature. Now, I know there are a lot of concerns about alert fatigue. I want to emphasize that communication in the hospital now is not what it's going to look like in 2 weeks' time, in a month's time, in 6 months. So I'm doing a lot of work with our nursing colleagues around let's message wisely such that we're not interrupting people when they're doing visit clinical work, and really being judicious with our messaging. So setting several different categories of messages. And by the way, there's an option here for personalization such that you can say, I don't want to get dinged for normal messages that I only need to respond in an hour or 4 hours if it's on the patient side. I do want to get alerted for things that I need to respond to within 15 minutes. And then the system, we're going to hardwire the urgent notifications such that they will wake you up, they will break through your native phone settings such that you're not missing those things. So a lot of opportunities for personalization, being able to set each of these to a different tone so you know how quickly you need to respond to that. Again, significantly better than a page of you don't know the urgency of that page. Tackling that wake up thing. So you can totally customize these things, but the important messages will repeat and the urgence, as I said, will break through your native phone settings. You can also do a whole lot with your phone now where you can say, do not disturb from texts from your mom or your kids or whoever's alerting, might be messaging you don't want to get alerts from in the middle of the day or the middle of the night. But you can say, except for this mobile application, let any messages from there through. So again, a lot of opportunities for personalization, depending on what your clinical responsibilities are. On the other side of the privacy thing, I know there's a lot of concern about using your personal device for work in terms of being open to subpoenas. So this BYOD policy that Amy and her team crafted really clarifies what was already true. If you're using your personal device for work, for whatever that looks like, as a state employee, you're subject to open record requests and statutes. So that doesn't change with any of this stuff now. And by the way, anything that's on a secure server, whether it's through the secure mobile application or through your email, anything that needs to be queried from an open records request can query those servers, not your individual device. Now, if you do happen to do things for work that's through text messages that's not through these secure mobile applications, then yes, they could request things from your device. However, the requests have to be specific to the content and the date and the time. So it's highly unlikely that you would really never have to submit your entire phone to say, read through all of my personal text messages, because that wouldn't be open to the subpoena. It has to be specific to the content that they're looking for. And this is relatively well established in Colorado case law. A couple other things that have come up. Can you work at multiple institutions or receive notifications from multiple institutions, all through the same Epic Haiku mobile application? The answer is yes. You can be signed in at Denver Health and at Children's and at University Hospital and get dings from each of those through the same mobile application. A lot of work is happening in the perioperative phase of what if I'm scrubbed into a case. Depending on the institution, everyone's kind of doing this differently, but a lot of technology features here including auto procedure forwarding, saying I'm signed into a case, so therefore I shouldn't be disturbed. Adding scrub nurses to the treatment team such that they can manage the messages similar to calling back your page now. And a lot of work happening in that space. And this is where I really encourage people to think, okay, how could we actually leverage this technology to be better than what it is now? A couple other things, this concern about signing in or signing out, that's really how you're going to tell people whether you should or should not be contacted. So keeping that up to date, saying I'm active for this patient right now, or I'm going home, you're going to want to do that actively, multiple times a day to say, yes, I'm responsible. No, I'm not, to tell the other people, give some guidance on who you should call, not simply relying on a thing that was put in place in the beginning of the year to say this person is active right now. AMIN is going to serve as a backup. It's going to auto-populate in case you forget to sign in, but we all know that AMIN is not always correct because of inefficiencies in putting things in. So that should think of as a backup, but you can auto-adjust things on the fly. Let's say, for example, you want to use a different phone number for the day because you switched with your kids or whatever. You can do that on the fly and say, today, this is the phone number that I want you to call, and put that in as you sign in. So really nimble and almost agnostic to the physical device that you're using. Couple things, a lot of concerns about what if my phone gets damaged. We talk about the backup devices. You can transfer responsibility to another device, like I said, or to another provider if you need to run out and get your phone fixed or whatever. You can say, I'm only available at this phone number. And like I said before, at each hospital, it's going to look a little bit different in terms of what backup devices exist, depending on your clinical responsibilities. And just to say it, if you're not responsible for urgent alerts for any of your patients, you may be able to manage all of these things through a desktop computer and not need any alerts through the mobile application. Last slide here, and then we'll open it up to questions from you all. I know there are a lot of questions of, well, I heard that nurses are getting phones. Why can't doctors just get work phones as well? Well, fundamentally, our workflows are totally different. So yes, nurses are getting phones to use in the hospital on their shift. This won't work for providers at university hospital, both for technical limitations. So if we were to do that for doctors using their own phone, using phones that they supplied, there's a lot of sort of technical features in there that make that hard. Also, we recognize that you're responsible for care at multiple different places. So we wouldn't want you to have a children's hospital phone and a university hospital phone and a Denver Health hospital phone. That moves away from our vision of multiple things coming through the same device. It negates any of that personalization stuff that I talked about. So being able to set different tones for different things, you wouldn't be able to do that on a group shared phone in an easy way. And then just to say, like, our nurses are held to different standards than our providers are. So nurses are monitored and actually encouraged not to have their personal cell phones out at work. We know that they do still do sometimes, but really, I think that's not something as providers that we want to say, you can't manage your personal work and phone stuff all at the same time. I think that's really not something that most of us want. In terms of how to, so we posted on our GME website, but everyone is welcome to go there. Specific hospital resources. There's a fabulous training guide in terms of how to manage and set up all these things at University Hospital that translates to Denver Health. There's a Denver Health page on there as well. And there's a lot of other resources for you to work through. And there's going to be more and more training coming out as this goes along. So a lot of opportunities to learn and play with this stuff, and I encourage you all to do that now. I'm going to stop talking. I'm going to pass it back to Dr. Fulbrigge, and happy to answer questions that you're all here to ask today.
Great. Thank you, Tyler, for giving us kind of that overview. And I had waited to ask you to put things in the chat because I figured there would be some questions that might be even answered by that preliminary information that Tyler had given us. But now I think the most logical way is if you have a question, if you would just put it in the chat now, and then we can systematically go through them. And that will probably be the most organized way to do that. As we're waiting for people to put anything in the chat, I guess Kelly, Amy, or Patrick, any comments based on what Tyler has said, or anything that's come across your desk in the last couple of days that you wanted to emphasize for the group?
So I'll go first. I really wanted to emphasize the difference between an open records request and a subpoena. So an open records request is something that every single person that works for a public entity like the government, like Department of Revenue, CDPHE, any insert whatever public entity you want, we're all subject to open records request. That does not include PHI. It doesn't include medical records. And so when there's a CORA request, it's going to be a scope that is work-related communication. So we're not going to be asking for, the request is going to be asking for pictures of your kid, text messages, things like that. It's all going to be tailored towards something that's university communication. In contrast, a subpoena could actually be for basically everything, but if it was for something that was personal, we would work with the request to limit it to something that's directly related to your job. So it has to be a scope that's related to the job and the patient care and things like that. And so the subpoena would be for UC Health, for Epic records, and it would not impact you. So just wanted to clarify those two distinctions because they can be, they're similar, but a bit different.
Okay, great. Thank you. So we'll go ahead and start with the questions that are coming in, unless Patrick or Kelly has any other comments.
I'd say it was a very thoughtful presentation. Appreciated. The one thing I would say is this is a very quickly evolving space. So we are trying our very best to get personal cell phone numbers out of the mix as fast as we can, and are helping Epic lead that development. And we anticipate having some of those functions live within the next 12 months. So bear with us a little bit on that front. We all have the same goal on protecting the use of your personal numbers. It's just going to take us a little bit of time to get there.
Thanks, Patrick. So Kelly, otherwise I'll go ahead and get started. Okay. So the first question is, what is the plan for providers who cover call and provide services at St. Joe's Hospital? I know we had some initial conversations, Tyler and Kelly, with our colleagues at NJ and those that cover it at St. Joe's. Do we have any update on what those discussions have been?
And I think Tyler answered in the chat is correct. The same concept. It's just simply we're going to move to using the cell phone for the main point of contact, which most people in general are anyway. But lots of people are forwarding their pager to their cell phone, et cetera. So at the VA, as Tyler described, and then also at St. Joe's and Jewish, they'll contact you via your main contact in Amion.
Okay, thanks, Kelly. A second question here is, are there guidelines for providers to judge what is important or urgent? As a pathologist, I often get paged about preliminary results or asking for a case to be finalized for discharge. I think there is a difference of opinion for how urgent these messages are. And I agree, and I think some of that we will have to learn as we roll this out. I think just as we've also been working on this just about within Epic and My Health Connection and messages, staff messages in there, what's an appropriate message, what isn't. I think this will also be a learning curve between us and our colleagues, right? And I think one of the things I would ask is that we educate and inform our colleagues if you think there is a difference on what you think is urgent or important versus what they do in a professional and nice way. I think everybody is working closely on this to make sure we minimize things that are not urgent, but also get the important information across. Kelly or Tyler, any input further on that?
Yeah, I think there's an opportunity. We encourage all teams to get together and talk about this stuff. Not only the backup stuff of what happens if my cell phone goes down, to have backup options in place, but also what do we all as a group, whatever your group looks like, what do we all agree is internally? What do we think counts as normal or important or urgent? To do some of this teaming and to think of internally, how do we want to communicate? And I think that'll help alleviate a lot of concerns and bring up new discussions that probably have been in the background for a really long time.
Yeah, and I would just echo Tyler. So you flashed it up as part of your slides, but this notion of message wisely. So if it's something that is time sensitive, then you should do some sort of an interruptive communication. Maybe it was a pager before, maybe it's a secure chat, maybe it's a phone call. But if it's not time sensitive at all, then we shouldn't be interrupting anybody's workflow. And there are other ways to communicate things, in basket, waiting for somebody to come by, waiting for rounds, that sort of thing. Agreed, though, that we all are going to have our conversations with our teams to make sure that folks understand what is time sensitive, what is important, and what is appropriate to interrupt us in our workflow for.
Okay, great. Next question. So your solutions for work-life balance rely heavily on sign-in, sign-out functionality. This does not address the concern of the primary care provider who is listed as the PCP clearly in the medical record for every patient they care for. As my patients cross the healthcare system in numerous ways, day and night, and any provider in any setting may reach out to me at any time, both by haiku and now by personal cell phone number. How are we protecting PCPs from burnout? And where is the guidance for how to use the offline status? First of all, I would say that, you are listed as a primary care provider already now, right? So they see you. And so, as far as staff messages and other things can go, I think the same thing is going to be possible with the secure chat messages also. But again, we will need to be able to understand what status you want to be as far as being notified, not notified, being offline. How do you want to be available for your patients during certain times of the day and night? I think there will be a learning curve on this, just as we talked about before, just as there is a learning curve right now on what you get for messages and other things, the way you communicate with your colleagues about your patients. So I guess I would say that I think the functionality is important about how you can be altering your availability for secure chat messages based on what you're doing that day. Tyler or Kelly, any thoughts on that?
No, I agree. I think, Ann, you're exactly right. We just have to, what we need to know is how to manage our device. And I think, Patrick, not to put you on the spot, but I think you say it really well, right? You should manage your device. And this actually gives us a whole lot of ability to control much differently than when we were carrying pagers, or if people already had our personal cell phones and getting to it. As long we know how to do this, we can put the thing down, we can tell it we're offline, or we can say, I only want to hear urgent, but everything else I don't want to hear about. There's a lot of opportunity. All you have to do is learn how to do it, just like we've all learned the rest of our devices that we manage, and then you're in control.
So the beauty of the way that this was designed is, let's say at the end of the day, and what we've said over here at Children's is, when you're done for the day, or you pick something in your life that you do frequently, like as soon as you get in a car, for instance, or something that triggers you, you can mark yourself as offline or do not disturb, and you can tell the system when you'll be back. So it's just one step. When you get good at it, it takes about 10 seconds to do. and it will stop messages for the rest of the night. And if you're going on vacation, tell it when you'll be back from vacation and get a little spring in your step from having done it. You know, it's kind of a good feeling when you put that, you know, offline status in there because you're taking a trip to Hawaii. So I think this works. And in the future, kind of going to what I mentioned about phone calls, we're going to embed the calls in Haiku. And Haiku knows when you're offline. So you're not going to get phone calls when you're listed as offline. We just need a little while to get there. So we appreciate your patience on that.
And I think I would also, highlight the idea of, again, remember, when you put offline status into the messaging system, it knows and it will message the person who is sending you that message that you are not available. So therefore, they know they have to go find someone else. It's not like it just goes into the abyss and they're not sure whether you're going to call back or you're not going to call back. And then maybe 20 minutes later, they say, oh, they never called back. They're actually going to get that message. You are not available. And they need to go down the list and figure out who else is responsible for that patient that can help them at that time if it's time sensitive. Okay, Tyler, you just put a link in for the reference guide on how to change your status, just as another way. And there's going to be a lot of this information that's available for people. And I think I would also highlight the comment that Tyler made a little while ago, which is the functionality will be going live imminently. And to start playing with this, as it starts to come online, even though pagers will still be available for a while, which is our old familiar backup, but it is archaic. And I think once we move to this new system, I think once we get over this fear and this hump that this is a change and this is different, I think we will be quite excited about the functionality that will be here even now and what's coming to allow us to have a more seamless transition between work and home life, and know that you can get the things that you need to get, but transition away when you are not available in an easy and efficient way. So I think there will be a learning curve here, but I'm really excited actually, because I think it's going to be a big positive for our work-life balance as we move this forward. So other questions for the group as a whole? We do have another couple of town halls scheduled later this week. So if something comes up, you can either just send me a message, we can add it to our FAQs, or you can join in for one of the other sessions later on in the week if some additional questions or concerns come up. But we really want to be available to try and make sure we haven't missed anything. There have been a lot of people spending a lot of time on this to exactly think about what if, right? But that doesn't mean that you might not have some idea that we should think about slightly differently, and we'd love to hear from you. So please reach out if you have further questions or concerns. I don't see any more questions in the chat right now. We can wait for a minute to see if anybody else has something they would like to. Oh, wait, here we go. Who is responsible for oversight of messaging wisely? And what is a recourse for inappropriate messaging? When are physicians being trained on message wisely? And who is deciding what appropriate communication looks like? And is training required? Kelly, do you want to talk a little bit about some of the initiatives that have gone on at the University Hospital about message wisely?
Yeah, I guess so. It's hard, as everybody knows, which is why we're doing these town halls, to actually try to get to another way to communicate with people. It's hard to communicate with everybody. So we actually rolled out the Message Wisely campaign April 4th. With the idea of upstream from all of this other stuff coming to try to get that message out there, which is very clear, as I said, and as Tyler said, time sensitive, interrupt somebody. How time sensitive is it will determine your priorities. And then if it's not time sensitive, don't interrupt people. So we rolled that out. It was out in multiple different places in multiple different ways, and will be part of the rest of the information that's coming out as well. Look for QR codes going up in units. Look for QR codes going up in bathroom stalls. That's the kind of thing that we're trying to get, so that wherever we can find you, at a town hall, if you like to do it asynchronously by looking at the reference guide, or if you're in a break room somewhere, we're going to get all of that stuff out to you. But the Message Wisely actually went out both to nursing and other ancillary staff, as well as providers. And we will continue to iterate and reinforce. In terms of accountability, the ask actually is that we are accountable to each other in a collegial and professional way to help people, as Anne described, get up that curve of the learning curve of, I didn't realize that if I was asking you to expedite a diagnosis because I'm trying to discharge a patient, I didn't realize that that wasn't important to you, and vice versa. You might not realize it's actually really important to patient capacity. You know what I mean? So there's an opportunity for us to share what we might have differences into what we think is important.
Kelly, I think the other thing that I'll add here is that, right, like Epic is getting smarter. They're coming along and learning from the cell phone companies that have, frankly done a lot of work to be able to silence individual communications or individual groups, to be able to add emojis and other things. So this will continue to get better and will naturally evolve over time. So there's already a lot of work going in to place to say, how do we want to communicate with each other and what are the kind of natural evolutions of these things? The other thing, Jana, that I would encourage you to do is sit down with your team and say, how do we want to communicate with each other? What do we think is urgent? What do we think is important internally? And then you can at least sort of control your sphere. And the last thing I'll say, at least at University Hospital, is one of the things that we've identified on the inpatient side is that nurses presently are managing all their communications through a desktop, so they can send a bunch of messages and then walk away and not get alerted. As we distribute phones to nurses, they're going to learn pretty quickly, oh, wow, that's what it's like to get 6 dings at one time. Maybe I should stop doing that to the people that I've been doing that to as well. So again, a natural evolution and a lot more functionality as this technology evolves. And just to say it, both Kelly and Patrick are on the Epic steering committee talking about this stuff. So being frontline and being able to relay it to big Epic Wisconsin to be able to make the changes that people need.
The other thing, Patrick, I saw you come off mute, so I'll let you speak. But the other thing to just say is, right, it's human nature to want to respond and close loops and do things, right? So one of the things that is coming with the upgrade is this idea that you can respond in a way that allows somebody to get that human connection of, I heard you, I got this, without re-interrupting you. So as Tyler just said, emojis are coming. So the idea, just like we do a little thumbs up, it sounds different, on your phone that you don't have to pick it back up and look at it again. That sort of thing, that's the kind of stuff that Epic is actually learning as they go forward. So lots and lots of really cool things. And it's not Epic in 5 years, it's Epic in a month. And then it's an Epic in 3 months. So when we say VoIP is coming, it's coming probably in less than a year. It's not a 5-year and maybe someday it will get here. So this will just continue to get better and better.
Yeah, I think that the emojis have been in use at Children's now for a couple of weeks, and people are starting to quickly adopt them, to your point about fast adoption of these features. And we have confirmation that VoIP will be available starting, depending on the upgrade cycle, probably sometime by the end of the year. It's 2 upgrades away in a quarterly basis, and at Children's will be one of the 3 pilot sites turning it on in November. So it's coming very quickly. And I think in talking with our quality and safety teams, we're all really looking forward to being able to place calls within Epic, because there's going to be a choice then at that point. Do I want to send a secure chat message to this person, or do I just want to call them? So we think it's actually going to, in some ways, lower the secure chat volume of messaging when it's just more appropriate to have a quick phone conversation. But I want to stress Epic built VoIP, which is our a fancy way of saying the ability to do a voice call within Epic in a way that it respects those secure chat statuses. So if you try to call somebody offline, it won't work. Can't even place the call. So when you go on vacation or you want to go to bed, something we should be allowed to do, you will be able to do that with no interruption possible from this. So that's a big win, because with other communication methods, it doesn't always work that way. So this is really our future. One app, one device, keep it simple.
And I think I would add just that ability to have those statuses, and especially offline, where you don't then get that call, which you might have gotten otherwise. So if we go through everything with this unified communication strategy, it will protect the time when you want to be away and can be away from the time when you want to be available and can be available. And so I think it really is going to help in that balance between work and home. And I think we're, got some critical advantages as this is moving forward as we speak. So I'm really excited about it. So any last questions? Again, 2 more town halls later this week. If you'd like to join us once again, or you could send me just an email, because we're adding our frequently asked questions. We're creating this list that's up on the Clinical Affairs website, so that if you do have further questions, you can send them to me and we'll add them to the list. Thank you, everyone, for your time and attention, and I appreciate your input and discussion.